Hi everyone, can you hear me? Good evening everyone. Lisa? Hello, can everyone hear me?
Yes, we can, Dr. Please proceed.
Okay, thank you so much. Good evening everyone. As we start this evening, thank you so much for joining us. We do apologize as there are some technical glitches that are to be anticipated just with the change of weather and the area
Hi, Dr. Karanja. Seems to have lost.
Hello? Hello?
Hi, Dr. You're dropped off. Please proceed.
And I apologize for that. Ariana, if you could unmute, please, and start.
Okay, so good evening, everyone. and welcome to the Kenya National Forum for Child and Adolescent Health. My name is Ariana Kamau and I am 13 years old. I have the pleasure of being the teen moderator this evening. I had the opportunity to review the Sustainable Development Goals, and I got to find out that I am part of the largest population in the youth of history. There are currently 1.8 billion young people aged 10 to 24 years in the world, and in Kenya, those aged 10 to 19 years old are 11.6 million. This was mind blowing for me. Young people like me can make a difference in improving our communities, and that my voice counts when it comes to things that protect my health and well being. It is conversations like the one we're about to have this evening that are important for us to understand that our health is truly our wealth. Our panelists today are Dr. Christine Wamburu, the head of the Division of Adolescent and School Health in the Ministry of Health, Dr. Makeba Shiroya, the Technical Officer, Child Adolescent Health at the World Health Organization Kenya Country Office, and my co-moderator this evening, Dr. Njeri Karyanjahe, a consultant pediatrician in adolescent medicine specialist at the Gertrude Children's Hospital. Before we begin, we will give a few minutes to the chair of the Kenya Pediatrics Association, Dr. Lawrence Okongo, to make some opening remarks. Please feel free to put your comments in the chat, and Dr. Njeri and I will be monitoring it. We will answer the questions at the end of the presentation. Thank you.
Thank you so much, Ariana, for that. Dr. Okomo, if you could unmute yourself.
Thank you very much, Ariana and Jerry. I hope I can be heard.
Yes.
Yeah, so thank you once more. It's my pleasure to welcome everyone to this session. Sorry for the background noise, but if I can be heard, we just proceed. When we came up with the idea of joining the international community through the International Pediatrics Association to celebrate the day that makes us put the adolescent health and welfare into perspective. Little did we know that we'll arrive at this today, and it's really become a reality, and we are looking forward to ensure that issues touching on adolescent health and welfare of adolescents become a part and parcel of the activities and the focus of the Kenya Pediatrics Association. This meeting, as Ariana has said, is in partnership between the Kenya Pediatrics Association, the World Health Organization, UNICEF, the International Pediatrics Association, which is actually coordinating more than 15 similar activities across the globe, and also various other stakeholders that I may not be able to mention. We all know that adolescents many times are neglected or ignored because we often think that they are healthy and they rarely experience health challenges. And many times we do not focus on them a lot. Yet even locally, data, as much as it is very scarce, published, and we often reference the work done by one of our own, Dr. Boniface Osano, shows that when these adolescents are admitted, their outcomes are as bad as the outcomes in other children. So it's actually not true that they have fewer or less health concerns. For us, this is a special population that we need to focus on so that we ensure that the energy that they have is harnessed and any health challenges that they face are actually addressed. And who better placed but the pediatricians and the other healthcare professionals that take care of the health and well-being of these children. So mine was simply to say a few remarks. Already I've said a lot. To welcome all of us, to listen to our speakers, And also looking forward to all of us to join us as we prepare to launch the Kenya Adolescent strategy, which we hope will be done some early next month, and which I hope that Dr. Christine Wambugu is going to also allude to. Let's sit back and enjoy the presentations. I hope that it will be interactive because all of us are stakeholders, and the mere fact that we have logged in means that we have adolescent health and well-being at heart. Thank you very much, Njeri, for organizing all this, and also the ITA, who are our key partners, as well as the UNICEF and the WHO representatives. Thank you very much, and welcome everyone to the session.
Thank you, Dr. Okongo. So we'll quickly jump to our first presentation. Now, if you could just project the slides. The first slides were Dr. Shiroya's. Karibu sana, Dr. Shiroya, and you can direct Kamau in terms of progressing the slide.
Great. Thank you so much, Dr. Njeri, and thank you to everybody who's here. Can you hear me? Just a quick sound check.
Yes, we can hear you.
Perfect. So it's my pleasure to be part of this very important conversation around adolescence. And in this presentation, what I'll attempt to do is just first put the context within the African setting as to why adolescents are important, and then try to link a little bit to the Sustainable Development Goals. The next slide. So we know that now adolescents are an increasing proportion in low and middle income populations. And in this slide, we see that over the last, maybe even from the 1950s to now, there's been a very steep trajectory increase in the number of adolescents in the continent. And it is projected by 2030, there'll almost be 320 million adolescents in the continent. We know that the adolescents coming of age is fundamental for behavioral change, as well as other social and productive citizenship. And therefore, it's important for us to really appreciate their growing number in the continent. The next slide. In terms of their proportion by sex, we note that generally it's almost a 1-to-1, although the male to female ratio is a little bit higher for males, but generally it's been a steady growth. It's almost 1-to-1 for both females and males. And this is important when it comes to programming, because the health needs for both female and male differ. But here we see that our programming should factor the fact that both proportions are almost equal across the region. Our next slide. When it comes to the African region, the countries are classified into high, low, lower middle income, and then upper middle income. And we note that in the upper middle income countries, South Africa has the highest proportion of adolescents, where Nigeria it's among the lower middle income, followed by Kenya, and then Ethiopia has the highest proportion amongst the low income countries. And so this is and this again helps us to understand where the emphasis needs to be in each of these particular income brackets, and how we should be able to take a multisectoral approach as we try to put in the health interventions for adolescents. Next slide. The trend, this again is trying to put context into what is the likely scenario as we get into the next few years. And we expect the trend to generally continue to be high, but not necessarily increase with the same trajectory as we had before. So it will be a steady increase, almost plateauing, almost as we go into the subsequent few years. And this might be because of some of the interventions related to adolescent sexual reproductive health that many countries are putting into place. I don't see the presentation. I'm not sure if everybody else can see it. The slides are no longer showing, and I can see.
Yeah, I also cannot see the slides. Kamal, do you mind showing the slides again, projecting them again?
Excellent. Thank you. Now we can see them. Thank you. So we go to the next slide. Thank you. So at the at the Afro, the regional office, a lot of time is spent in trying to just analyze exactly what the trends are across the countries, because this helps when it comes to peer learning or even exchange of knowledge information. So generally, this slide again tends to show that when you look at proportion of adolescents in the country populations, more or less about 25%, almost 25% of most country populations are adolescents. And this, I think, mirrors what we see in Kenya, where almost 23% of our population is actually adolescents. So it's, but there are countries such as the Central African Republic that have a little higher than that. They're going up 26.2%, while there's Mauritius is at 13.8%. But by and large, we have a very young population. Adolescents are almost a quarter of most countries, or country populations across the African region, which just shows that there is need to really focus on adolescents. They have been neglected for a long time and have been left out. Yet they are very diverse, they live in dynamic contexts and are really facing unprecedented challenges, including complex burden diseases that take a multidisciplinary approach in terms of interventions. Next slide. So this slide is probably similar to what we've already seen, just re-emphasizing the fact that there is a trajectory that is, we've had this upward trajectory, but here we're trying to look, we know that adolescents are classified into early, middle, and late adolescents, and and disintegrating that, we note from this slide that actually it is our young adolescents who are the higher population. So our 10 to 19, as opposed to the youth who are the 15 to 24. So our programming also has to be reflective of the different age groups, and then it can be specific, interventions can be targeted to the specific age bracket for the adolescents, so that it is early, middle, or late. And some of the statistics maybe that will be shared by Dr. Christine will show that maybe we need to think about that as we look at health interventions in order to be able to meet our SDG goals. Next slide. So this slide is beginning to look at some of the health aspects that affect health. We know that out of the different interventions in SDGs, the health is the lead actor, and possibly it is also dependent on all the other factors relating to poverty and economics. They are the social determinants. So here we're looking specifically at the fact at the birth rate in the African region. And on your left side, you'll notice the graph attempts to show what the rate has been between 2010 and 2018. And by and large, there has been a reduction, a steady reduction in the African region. And now we're almost at about 99 births per 1,000 adolescent girls. And although there's been a decrease in the rate of adolescent birth rate in the African region, it's still quite high. And this, if you dig deeper into the different countries, you'll find that there's variation and disparities even within countries, as we even note in our own Kenyan region. Globally, of course, we still are one of the highest in terms of adolescent birth rates in the world. We're at 99, as we see in the Americas or even Europe, where it's much lower. So this is an area that, as we look at attaining the SDGs, especially some of the targets related to adolescents within each of the SDGs, the aspects around adolescent birth rate need to be focused on in a very purposeful way, and bearing in mind some of the contextual differences within the different adolescent groups. Next slide. I think this slide also just purposes to re-emphasize the adolescent birth rates in the different countries. As we said, Africa is at 99, but there is variation within the different countries. And some of the Central African countries and Western African countries are quite high. The highest is 229 for Central African Republic, but Mauritius is quite low at 29 in Algeria. And so, and in the table on the right, the analysis is related to the actual fertility, the high adolescent fertility rate it's 2018, so it's a little bit older data, but it still serves the purpose of showing that it is the same top countries in Central Africa that need to have a more targeted approach in order to be able to address the aspects related to adolescent fertility. And this has a compound effect because adolescents being pregnant has an effect on their education, and this directly relates even to the health and economic outcomes, both of the mother and of the child. And therefore, averting this by purposely addressing the factors that affect adolescent birth rate, adolescent fertility is very important for the different countries, and is an area that WHO is supporting countries to think through. Next slide. And this, I think this again purposes to really look at the age between 15 to 19, and because they're the most vulnerable in terms of the groups that you'd like to target when it comes to interventions. And it's similar to what we've already seen in the other slides, a large high rate in our Central African and West African countries, whereas the Northern African countries and Mauritius have a lower rate. Next slide. Again, related to the SDGs, we're looking at the literacy rate, because the literacy, all the interventions that take place outside of health, all the factors that affect the other aspects of the SDGs have a direct impact on the health of and well-being of the adolescents. So looking at the youth literacy is a key aspect of trying to attain some of the SDG goals for health in adolescents. So in this slide, we're looking at literacy rate in the African region, and we note that the youth between 15 and 24 years, only 23%, less than a quarter, are literate. And the literacy rate is highest in Zimbabwe, followed by Mauritania, and lowest in Cape Verde. And when it comes to the females, I think this disintegrates it into both the female and male. Then we note that generally the literacy rate is higher in male than it is in the females. And so as we look at our interventions, I think we're appreciating more and more that the health interventions need to be done in collaboration with other sectors. And it is difficult to be able to tackle, to improve the health and outcome of adolescents without taking a multi-sectoral approach, and working closely with other sectors such as education, trade, even water and sanitation, so that we can be able to address some of the issues that are related to health through this multi-sectoral approach. And you need to therefore align your interventions in this regard and implement them within this context. Next slide. So we are looking in this slide at around the deaths of adolescents in the African region. The analysis was done by our Afro-regional office. Between 2000 and 2016, what were the leading causes of death and how did it affect the male, females, who were more affected? We note that there were more deaths recorded among adolescent males than females in the African region, and that this gap has gradually widened. And some of the leading causes, based on the data available, relates to diverse causes such as road injuries, infectious diseases such as meningitis, and lower respiratory infections. And it shows the complexity the burden of diseases that the youth actually face. Also, in addition, we also have mobility due to non-communicable diseases. And this is related actually to some of the inequities in economic inequities and poverty. Again, showing that we need to be able to address some of the social determinants of health for adolescents in order to address their health indices. Next slide. This slide depicts the proportion of young people aged 20 to 24 who are married or in a union. And it is across the African region. And in 2018, we had 37% of females compared to only 4% of males aged 20 to 24 who are married or in a union before the age of 18. Central African Republic, which you recall had one of the highest rates of adolescent pregnancies, had the highest proportion of young people that were married or in a union, whereas Algeria had the lowest. And the early marriages are a risk factor for some, not only poor progression in terms of education, but it's an outcome for poverty and other economic factors. And also in some of these regions, you also have a higher risk of gender violence, as well as GBV, as well as FGM. And so it's important to note this slide and even to appreciate the fact that delayed marriage and interventions that will be able to ensure that happens are very important for outcomes for adolescent health and even for subsequently for children in general. Next slide. As relates to adolescent sexual reproductive health, again, where the study was done to look at the contraceptive prevalence amongst girls aged 15 to 19. And this slide also attempts to show the diversity in terms of the proportion across the region. We know that there are legal aspects, the legal framework, and the legal environments in the different countries also influences this, and the availability of the contraceptives for the young girls. And currently, we know also in our country, this for those less than 18, it's been a debate in terms of whether we should avail them or not. But the important thing to note is that 17% of females in the age 15 to 19 in the region who were married or in a union were using at least one method of contraception. And this also is important because as we look at the rate of adolescent pregnancy, we're trying to reduce the rate of adolescent pregnancy, and therefore the discussion around how to support the minors who are in a union continues to go on, and maybe it's something that will be alluded to in this discussion. Next slide. The demand for family planning, again, around our adolescent group of 15 to 19, 43% of females aged 20 to 24, that's among the youth, and 35% between the age of 15 to 19 had their family planning demand met. Because recall, if they're in unions or in marriages in their teenage, then they are exposed, so they do have now an increased demand for family planning. And therefore, the assessment that was done, it still shows that for those who are in a union, meeting the demand is it's quite low, and that there are various socioeconomic factors related to this that may need to be addressed in order to be able to address the need and the demand. Next slide. One of the key causes of motility and mortality, as we noted in the earlier slides, was related to HIV. And this slide shows us the ART coverage among adolescents between the age of 10 to 19, and the data is a little bit behind. It's a bit old, but I think the trends generally reflect what we see even at country level. And there still is a high need. We're not reaching the targeted ART coverage. And at that time, it was only Algeria and Namibia that had reached 90% of ART coverage. And most countries hadn't reached that level. And in fact, some of the new infections were now being found among adolescents. And therefore, looking at how to address this in order to be able to reach the health goals for adolescents, looking at the ART coverage and ART programming in our HIV programs continues to be a key area. But the question is the how, and many times it relates to understanding that you must take a multisectoral approach in order to be able to address, because there are various intersections with other factors such as the poverty, such as economics, even things related to criminal justice and other inequalities, housing and food security, all affect the health of an adolescent. Next slide. In this slide, we are trying to show pregnancy in adolescents, and the figure on the left shows the proportion of teenagers who had begun childbearing. And I think it is similar to what we've seen before in terms of the adolescent pregnancy rates. So we are noting that it's still the same countries that have a higher proportion of teenagers in the childbearing rate. And we may find some of the same countries as we go on also have some higher rates of, for example, violence against children and even adolescents, some of the issues around FGM, and all the different factors have some relationship, and the compounding effect is what we are seeing here in terms of both pregnancies and poor outcomes for the adolescents. So the summary here is that you have a quarter of all teenagers in the African region had begun childbearing, which is a really high proportion. And Mozambique had the highest proportion of teenagers who had begun childbearing, whereas Rwanda and Burundi had lower proportions. And so just moving on really quickly, I think we only have a few more slides. If they are repetitions, I will ask that we skip them. I think this slide is important. It relates again to the issues around gender-based violence. And I think what we'd like to note is the Central African Republic had some of the highest rates of adolescent pregnancies and a high proportion of adolescents in unions or marriages. And we see here that they also had the highest proportion of gender-based violence according to the study done at that time. And so again, the need to be able to address some of the GBV needs a multi-sectoral approach in order to then address the health issues that affect adolescents. Next slide. This slide also re-emphasizes that I'm cognizant of the time, so I'm trying to just go skim right through to any new slides. Next slide. Yes, turn to another slide. I think what the key take-home points that we would like to bring out is that the social determinants of health are key in addressing the multiple health burdens that face adolescents. Even as we looked at the issues related to health and linked them to achieving the SDGs, we recognize that a lot of them have social determinants of health as drivers. And we know that in order to address the health issues, we will need to be able to address this, and therefore the need to take a multi-sectorial approach. Even amongst the SDGs, health is still a leader, it's still one of the lead actors, and depends on the other factors related to economics, related to poverty, related to criminal justice, and even to violence in order to reach that goal. And once you understand this, then it is possible to be able to align your policies and some of your interventions at national and program level. And I believe the Ministry of Health, through the Division of Adolescent and School Health, is doing an excellent job about bringing the various players onto the table to be able to address and some of the adolescent health issues that are facing our country. And so with that, I'll kindly end my presentation and hand it back to Dr. Njeri. Thank you very much.
Dr. Njeri, I think you're muted.
I see a message. Okay. Oh, there you are, Dr. Njeri.
Hi, can you hear me? Oh, I am so sorry about that. I'd like to thank you, Dr. Shiroya, for sharing your insights with us, and invite Dr. Christine Wambugu, a key partner in terms of adolescent health and well-being at the country level as part of the Ministry of Health and heading the Division of Adolescent and School Health. Karibu sana, Dr. Wambugu.
Thank you so much. Greetings all, good evening. Just confirming that everyone can hear me.
You are breaking up a little bit, but we can see the slides.
Can you hear me now?
Yes. Hello, Dr. Wambugu?
Hello, just confirming that you can hear me.
Yes, now we can hear you.
Okay, good evening, everyone. Thank you. Mine is just to express gratitude for this great interest that we are having in adolescence. I think they've, for the longest time, being the neglected cohort of children. So we are really happy and excited to be having this focus on adolescence. And the theme of this celebration is actually in Kenya, 11.3 million children, adolescents. So I'll just pick up from where Dr. Karianjahi left off, and I'll give an overview on the status of adolescent health in Kenya. We can go to the next slide. As Dr. Makeba has said, 24% of Kenyans' population are actually adolescents. So there are more young adolescents, about 6.3 million, and slightly less adolescents, about 5.3 million, who are between the ages of 15 to 19 years. So even as she alluded, as we are programming, we should be keeping these differences in mind, knowing that we are programming for a larger proportion of younger adolescents. Next slide. And when we look at the Kenya Population and Housing Census of 2019, we find that most of our adolescents are actually found in the rural areas more than the urban setting, as in the graph on the screen. Next slide. So I'll bring a little bit data from different areas. I'm sure most of you had our presentation about the Kenya Adolescent Health Survey that we did recently, but there's some aspects of the survey that we were not able to collect data for. So we triangulate it with different other data sources. So the next three series of slides that I'm going to present will be data that is from the Global Burden of Disease database that just looks at data over a period of time. So when we look at nutrition indicators for adolescents, the GBD data demonstrates that there's actually an increase in number of overweight adolescents, as we are seeing, and more in girls than boys. The obese adolescent is the red line, the overweight adolescent is the blue line, and sort of as a reduction in the number of underweight adolescents. Move to the next slide. So when we look at other behavioral risk factors from the Global Burden of Disease study, we see that there's a lot of heavy episodic drinking, 12% of adolescent boys and 2% of adolescent girls, 13% of tobacco use in adolescent boys and 7% in girls, and insufficient physical activity, almost similarly in boys and girls at about 85% to 89%. Next slide. So when we look at causes of morbidity and mortality using the same data sources, we can move to the next slide. So globally, regionally, in the East and Southern African region, and also in Kenya, we're seeing an increased number of adolescents who are suffering from mental health conditions that are causing a lot of morbidity. The depressive disorders, childhood behavioral disorders, and so on and so forth, anxiety disorders. And then for the girls 15 to 19 years, we are also seeing gynecological disease causing significant morbidity. We're seeing things like skin diseases, parasitic and vector-borne diseases like malaria and the likes, also causing a lot of morbidity, especially in the girls. Moving on to the next slide, we look at the causes of mortality. So the causes of mortality are slightly different. When you look at globally, the East and Southern African region and the Kenyan region, you're seeing road injury being the top globally and in the African region. And even in Kenya, you can see it's ranking second, third, at least it's the top 5 of all the age cohorts, of both boys and girls, young and older, adolescents. We have your TB, your lower respiratory infections, which includes tuberculosis, the HIV, the parasitic and vector-borne diseases, which include malaria. And for the girls, 15 to 19 years, we have maternal conditions. The real diseases are still featuring here, despite featuring as a major cause of death in the younger child. Moving on to the next slide. So as I mentioned, we had this adolescent health survey that we did, and the study was carried out in 44 to 47 counties in the country. And the survey showed that about 10% of adolescents reported that they were malnourished, with a regional variation of as high as 40% in the arid and semi-arid parts of the country. 3/4 of adolescents had a normal BMI, with 1 in 10 being malnourished, and also 1 in 10 were obese. This is seeing, as I mentioned in the first slide on nutrition, we are seeing an increase in obesity among our adolescents, especially those in the urban areas. Only a third of the young adolescents, 10 to 14 years, had adequate dietary diversity. And this improved in adolescents 15 to 19 years to 46, as reported in the Kenya Demographic Health Survey 2022, which is a slightly more recent survey than the Adolescent Health Survey, which was done in 2019-2021, and the KDHS was done in 2022. And then about a third of adolescents live a sedentary lifestyle. And it's worth noting that both poor nutrition, sedentary lifestyle are also risks for non-communicable disease in adulthood. And this is the ideal age where we need to tackle this. On issues oral health, we found that most of the adolescents have a toothbrush. However, only half of adolescents, 10 to 14 years, brush at least once a day. This improves to 3/4 of the older adolescents brushing at least once a day. And only 2% of adolescents reported ever having visited a dentist. So Kenya's made great strides in implementing school meals and nutrition strategy, which include both, that it's looking to address both macro and micro causes of malnutrition in school-age children. And we are also implementing WHO's recommendations on school-based deworming, annually deworming at least 6 million school-age children who are at risk for SDH and schistosomiasis. This is in line with the SDG 2.2, where we are looking at reducing the prevalence of malnutrition in adolescents. And what Kenya is committing in the upcoming Global Forum for Adolescents is to reduce the prevalence of low BMI among adolescents from 10% to 5% in 2030. Next slide. On adolescent HIV, globally, there were an estimated 1.3 million new HIV infections and about 630 AIDS-related deaths with 500,000 new infections. And 260,000 of AIDS-related deaths are actually occurring in the African region. In Kenya, adolescent boys and girls between age 10 and 19 living with HIV are approximated to about 90,000 and approximately 2,000 deaths due to HIV-related complications. Half of all new HIV infections occur among adolescents, and around 6,000 adolescents contract HIV each year, contributing to a third of all new infections in Kenya. We have the Kenya AIDS Strategic Framework that sets out an ambitious target to reduce HIV infections by 75%, reduce AIDS-related mortality by 50%, micro-eliminate viral hepatitis, and reduce the incidence of STIs and HIV-related stigma to less than 25%, and increase domestic financing of the HIV response to 50%. So in line with this, 3.1, Kenya commits to reduce the number of HIV infections among adolescents by 75% in 2030. Next slide.
Dr. Wambugu, you seem to have broken off.
So 10.6, yes. No, I can hear you. Can you hear me?
Yes, now we can hear you. Please proceed. Hello, Dr. Wambugu. Dr. Wambugu, you're breaking off.
So TB,
Hello, Dr. Wambugu, you're breaking off. Hello, Dr. Wambugu.
I think she has some connectivity issue. I say she's dropped off. Let me just try and follow. She's joined back in.
Oh, okay, thank you. Our apologies to our audience. Like I mentioned before, we are having a few technical glitches. However, Dr. Wambugu will be back with us shortly.
Dr. Njeri, I think I'm back. Can you hear me now?
Yes, we can. Please proceed.
Okay, thank you. So in 2021, Kenya, the TB case notification rate was 251 per 100,000, and 7,500 childhood TB cases were notified to the National TB program, and 68% of these were adolescents, 15 to 19 years of age. Keeping in mind, this is the age bracket that's usually found in the high school, and the NTLD strategic plan has set out also ambitious targets to increase case detection to 70% from 35% in this age group. And towards this, we are looking at increasing school-based TB intervention. And in line with this, the government of said in
Dr. Wambugu, you're breaking off again.
In 2030 program.
Dr. Wambuku?
Let's move to
Hello, Dr. Wambuku? Hello, Dr. Wambuku? Are you still online?
Can you hear me?
Yes, we can hear you now.
Okay, we can move to the slide. So on malaria in adolescents, in 2021, the malaria cases increased to 231 million and deaths decreased to 593,000. This is globally. Malaria remains a significant public health concern in Kenya, and 3/4 of the population are at risk for infection. So the recently concluded, okay, not so recently concluded Kenya Malaria Indicator Survey showed that adolescents 10 to 14 years had a higher prevalence of malaria at 7.6%. And the malaria strategy 2019-2023 outlines interventions to protect 100% of adolescents living in malaria risk areas through appropriate malaria prevention methods. This includes providing bed nets in schools and a lot of social behavior change, communication, messaging, among other interventions. So together with the National Malaria Program, there's a commitment under SDG 3.3 to reduce malaria incidence among adolescents 10 to 14 years from the 7.6% to 5% in 2023. Next slide. Next slide, please. Okay. So on HPV vaccination, we know that this prophylactic HPV vaccine have been in use for a long time. And the aim of this, the WHO has set out targets of 90, 70, 90. That is 90% of girls fully vaccinated with HPV vaccine by age 15, 70% of women screened with a high performance test by 35 years of age, and again by 45 years of age, and 90% of women identified with cervical disease who received treatment, 90% of women with precancer treated and 90% with invasive cancer managed. So towards this, we are looking at increasing the proportion of 15-year-old adolescent girls fully vaccinated with HPV vaccine to 90% by 2030. And this is the government's commitment. Next slide. Next slide, please. Thank you. On mental health, under this SDG, the focus was mainly on suicide, and globally about 700,000 people are estimated to die yearly by suicide, and suicide is the fourth leading cause of death among 15 to 29-year-olds. So I'm sure most of us have interacted with suicide prevention, trying to reduce approximately 4% of these suicidal tendencies. In the recently concluded Adolescent Health Survey, more than half, that is about 55% of all adolescents reported to having experienced one or more adverse childhood experience. And you find that these adolescents who have experienced one adverse childhood experience have a higher risk of attempted suicide and suicidal ideation to about 6%. So we are working together with the mental health department towards the government's commitment of SDG 3.4.2 to reduce the suicide mortality rates among adolescents from 4% to 1% by 2030. Next slide. On alcohol and tobacco use, the harmful use of alcohol results in about 3.3 million deaths each year. And according to the Kenya Adolescent Health Survey report, self-reported substance use was about 10% for alcohol and about 3% for cigarette use. KDHS also reports alcohol and cigarette tobacco use, and it reported those alcohol use among 15 to 19-year-olds about 3% for females and 6% for males, and tobacco use among 15 to 19-year-olds as 1% for females and 12% for males. So the government's commitment is to reduce the harmful use of tobacco among adolescents from 9% to 4% by 2030, and to eliminate the use of tobacco products among adolescents by 2030, keeping in mind that Kenya is part of the WHO Framework Convention on Tobacco Control, and we have ratified global commitment. Next slide. On road traffic injuries, globally, about 1.3 million people die yearly from road traffic crashes. And about 93% of the world's fatalities on the roads occur in low and middle income. Approximately 60% of the world's vehicles. The Kenya Adolescent Health Survey reported that about 95% of adolescents do not use seatbelts, motorbikes, and bicycles, and this can lead to a 42% reduction of the risk of fatalities, of fatal injuries, and 69% reduction in head injuries. And wearing a seatbelt reduces the risk of death among drivers and front seat occupants 45 to 50%, and the risk of death and severe injuries among rear seat occupants by 25%. So in Kenya, we have the Kenya Violence and Injury Prevention Action Plan 2018 to 2022 that is currently being revised, and it sets an ambitious target of 50% reduction in road traffic fatalities. So under SDG 3.6.1, we aim to reduce the death rate due to road traffic injuries among adults. Next slide. On SRH, I know Dr. Shiroya had really emphasized a lot about this. In our Kenya Adolescent Health Survey, we looked at some SRH. We looked at the median age for and developing deep voices, which was about 13 to 14 years in girls and boys respectively. And we're also looking at availability of sanitary pads and adolescents were able to access sanitary pads. But from the Kenya Adolescent Survey, this was very in some regions, only 40% of girls were able to access, and also part of the years and quarter 10-year-old girls reported that they did not know that have safe.
Hello. Could you repeat the last two statements?
Steadily declining. From Dr. Makeba's slide, she gave data of by Dr. Makeba was data of 2018 that showed 99 adolescent births per 100,000 female adolescents, but that was 2018. This has been steadily declining, and from the recent Kenya Demographic Health Survey, this reduced from 99 to 73 per 100,000. But what is to note is that when we look at the proportion of adolescents who've ever had a live birth, the young adolescents are reported as only 2.1% of those who are younger than 15-year-olds, and 4.2% of 16-year-olds, 10% of 17-year-olds, 16% of 18-year-olds, and 27% of 19-year-olds. So when you look at the 17, 18, and 19-year-old, they account for more than 3/4 of all adolescent births. So our young adolescents are not giving birth so much. And from our Kenya Adolescent Health Survey, you find that most of the sexually, the adolescents 10 to 14 who had a sexual debut, it was mainly due to GBV, and more of the live birth as compared to the younger ones. So more teenage pregnancy are occurring in adolescents 18 and 19 years of age. And we know these are one of their most formative years when they're transitioning from high school to colleges. And this tends to interfere with their pursuit of higher education and information. And this age group is actually eligible under the laws of Kenya to access family planning. So we are seeing that is an to help the adolescents. And so there's need to have a multifaceted approach to addressing the reduction in adolescent birth rate. As much as it is now, according to KDHS 2022, 73 per 100,000, still needs to come down further. So under SDG 3.7.2, the government commits to reduce by 50% the adolescent birth rate by 2030. Next slide. So on FGM, we know that about 75% of girls who've ever experienced FGM experience it before the age of 14. So this affects most of our younger adolescents. And we have committed as a government in the Generation Equality Forum of 2021, and Kenya is a global leader for the Action Coalition on Gender-Based Violence. We made commitments to end all forms of GBV and FGM by 2026. So the commitment of the government is to eradicate female genital mutilation or female genital cutting by 2030. Next slide. On interpersonal violence, the Kenya Demographic Health Survey 2022 reported about 20% of women 15 to 19 years have ever experienced physical violence. The Adolescent Health Survey reported that 7.9% of female adolescents and 5.3% of male adolescents reported ever having experienced sexual violence. But only 1 in 10 of those who had experienced sexual violence revealed who the perpetrators were and whom they informed the incidents about. So we see still a lot needs to be done around interpersonal violence, physical violence, gender-based violence. And we are committing to increase by 50% the proportion of victims of violence in the previous 12 months who reported their victimization to competent authorities or other officially recognized conflict resolution mechanisms, in addition to all the other interventions that have been outlined in the appropriate documentation. So under UHC, we are looking also, the government has made a lot of strides in UHC, which included the EduAfya, which is currently being incorporated in other health schemes. And the government has committed to increasing the number of adolescents covered by health insurance to 75% by 2030. Next slide. On promoting learning, competence, education, skills, and employability for all adolescents. Seen with the universal transition, most of adolescents are in school. However, there are still some concerns that's around schooling and the school health services. I'm sure most of us have been seeing the reports on the media, but there's a lot that the government is doing. Now, starting with the Adolescent Health Survey, now we have, published information on the state of school health services, where about 9 out of 10 of schools had improved water. 7 out of 10 schools were providing sanitary towels, but only 50 schools had sanatoriums or sick bays. And only 3% of schools that had them within the school compound. Only a third of schools had disability access. About a third of health clubs are managed by teachers. So under this SDG 4 and 8, looking to increase the proportion of adolescents achieving at least a mix to 100 by 2030, and reducing the proportion of schools not in of youth aged 15 to 20 years not in education and employment, or to less than 1% by 2030. And we see the survey reported that about 60% of adolescents had missed 1 to 5 days in school in the last 3 months. So we can see the role that healthcare has to play in meeting the SDG 4.1.1. Next slide. Under SDG 2030, ensure that learners through curriculum acquire knowledge and skills needed to promote sustainable development, including, among others, sustainable and sustainable rights, gender equality, global citizenship, and others' contribution to sustainable this societal contribution, which go hand with adolescent health. And most of these issues have been already embedded in the CBCC curriculum, but the Ministry of Health, together with the Ministry of Gender and the National Council for Population Development, have developed manual on parenting and giving information within our community to promote this adolescent connectedness, positive values, and societal contribution. And together with this, we are also looking at the support of the health facilities in providing the critical health services to the adolescents. Next slide. I think this should be one of the last slides. The other SDG of 16.7 is to ensure responsive, inclusive, participatory, and representative decision-making for adolescents at all levels. And one of the strategic directions of the Kenya Adolescent Health Strategy 2023-2027 is to develop lines on the meaningful engagement of adolescents in designing data-driven and evidence-based policies and programs, including program implementation, governance, monitoring, and evaluation. So the agency and resilience of adolescent health programs will also be achieved through global voluntary national reviews of these well-being commitments, and through accountability, country profiles, and said.
Dr. Wambugu? Hello, Dr. Wambugu?
Next slide. So this should actually be my last slide. We have this Kenya Adolescent Health Visualization Dashboard, and where the data from the Adolescent Health Survey can be seen. The detailed survey results can be found on the Kenya National Bureau of Statistics website. And anyone who also requires further analysis can liaise with the Division of Adolescent and School Health, together with KNBS that has the raw data to do any further analysis that may be required on the data that is there and is available.
Thank you so much. Thank you so much, Dr. Wambugu. That was such an enlightening presentation, and I can already see from the comments, people are already asking for the PDF of this presentation, given some connectivity challenges, and at the same time, it's such valuable information, and you direct us on the best way to be able to share the information. So just a few feedback. There's one person who has asked is, how is the Health and Education Ministries coordinating to reduce the rising number of hysterical cases in school-going children? And are there ways that we can be able to advocate for the adolescents who are over the age of 13 years in the public health system in terms of meeting their adolescent health needs and being able to take a little bit longer before they're transitioned into adult care. Dr. Wambuku, I don't know if you got my question. Hello? I don't know if
Yes,
Dr. Wambuku.
I think you could repeat. She had dropped off.
Okay. So what we can be able to do is probably take note of the people who had asked the questions and maybe be able to give them feedback in case Dr. Wambuku has not connected back. I don't know if she has been able to rejoin. Dr. Wambuku, have you been able to rejoin us?
Yes, I'm back.
Did you hear the two questions that I had asked? No problem at all.
I'm having connection problems, sorry.
That's okay.
Can
There
you
were
repeat
two
the
questions. So one question was asking, is the Ministry of Health, what are they doing in terms of the rising cases of hysteria that are happening with some of the school-going adolescents? And the other question was, are there ways for us as healthcare professionals to be able to partner with you and advocate to raise the age of pediatrics, especially in public hospitals, because there is quite a concern that when they're above the age of 12, they're being taken care of with adults, and even in some cases, geriatric cases. So I don't know if you have any feedback for those two comments, questions.
Thank you so much, Dr. Njeri. To all into that short presentation of the ministry together with the Division of Mental Health that is currently under Dr. Njuguna. There's a lot of focus on the social-emotional well-being of adolescents. We are currently implementing the Making Every School a Health Promoting School global strategy by W and UNICEF. We have begun doing this in 3 counties, and we hope to up. And under this, there are 8 standards that have to be ensured in school health programs, and one of the standards is the environment in schools. What you call it, psychology and psychiatry, just putting that well-being, the mental well-being in school, preventing harmful drugs. So that is a core component that is there. We also have, as I mentioned earlier, the suicide prevention strategy that the ministry has launched through the Division of Mental Health, that is also being used in schools, and we are also to form a network, a referral network for mental health cases from the schools out the mental health experts. Hoping we can use the model and transport it now to Sean. Sorry, was about. Please remind me, Dr. Njeri.
Which one? There's the one about raising the age of the one above age 12, because currently in public institutions, public hospitals, the limit is age 12 before they get transitioned into adult care. So how are we able to advocate for that age to be raised?
For me, it's an ongoing conversation. We engage process with the care providers, with the adolescents themselves, the pediatricians, the MOs, and the nurses.
Yeah. So it's an ongoing conversation, and I'm hearing that there are different avenues that we're trying to look into to try and see how we can be able to raise this age. Thank you so much, Dr. Wampuku. I'll just have two final questions and then we'll bring this to a close. How actively is the Ministry of Health and WHO using behavioral economics to inform interventions related to the reduction of teen pregnancy?
Apologies, Dr. Kanjahi. I think she's dropped off again.
Okay. Beatrice Gatumia, would you allow us to be able to have her respond to you? Maybe in the chat, you could be able to send a message to Kamauthi Bitie and we can be able to get your question answered because of the connectivity challenges. And I do recognize we have gone past our time. Thank you all so much for being patient with us. We really wanted to be able to share all this information with you. And I absolutely love the Kenyan spirit of being able to hang in there despite the change in weather, the technical difficulties that we've experienced during the course of the evening. However, I am very grateful that we were able to share this information with you. We will do our best to be able to get this information to you in PDF format, and we will speak to the presenters to avail that to us. On behalf of the Kenya Pediatric Association, I'd like to say a very big thank you for attending our webinar this evening. This is an ongoing conversation, and this is part of, we're building up to a global forum, which is 1.8 billion for change, which is the number of 10 to 24-year-olds in the world currently. And this was one of the forums that we had wanted to put together to work towards that. And as Dr. Christy Wambuku had mentioned, there are 11.6 million adolescents aged 10 to 19 years. And we need to be able to work towards preventing disease and protecting their health at all costs, because as Ariana had mentioned, their health is our wealth as a nation. So asanteni sana for all of you who are able to attend, and would like to wish you a good evening and looking forward to interacting with you via our social media channels for Kenya Pediatric Association. Asanteni sana and have a good evening.